Thank you, George, Roxana, for the invitation. So I'm asked to give a surgical perspective. I do not have a relevant financial relationship to disclose, but I need to disclose, first of all, that I am a surgeon, this is obvious, but also I was part of the writing committee of the 2021 ACC AHA SKY guideline. And I will focus mostly on the controversy between CABG versus medical therapy, because this is really what has been at the center of the debate. And this is the reason why the Surgical Society, in the end, decided not to endorse the guidelines. So it will not be CABG versus PCI this time, but it will be CABG versus medical therapy. And the Surgical Society are basically saying that we got it wrong. And so I will briefly look at the data that are the foundation of the current recommendation and see if the Surgical Society were right or wrong. I think we need to acknowledge that most trials comparing CABG versus medical therapy are old. They do not represent current practice, and probably more so in the medical therapy arm. There are few more recent trials that were generally small and underpowered to detect even moderate treatment effect in the surgical strata. In general, they show no difference in survival between CABG and medical therapy, but a statistically significant reduction in cardiovascular events. Ischemia, that is always used for this debate, should not be used for this reason, because it was not designed to individually compare the two revascularization strategy with medical therapy. So this is the classic meta-analysis that is generally used by those who believe that there is a benefit for surgery versus medical therapy. It was a meta-analysis published in 1994 in The Lancet by a group of investigators that pulled individual patient data from 7 trials of CABG versus medical therapy. Those are the 7 trials, and the first thing you need to note is that they were all the trials even in the 90s. Those trials enrolled patients almost 50 years ago, and actually in the text of the Lancet IPDMA, the investigator very clearly acknowledged that those trials may not have reflected the practice as it was in 1994. And if we look at the procedural detail of those trials, I think we have confirmation of that. The ITA was using 10% of the patient in the surgical group, aspirin around 20% of the patient in both groups, beta blocker diuretics all largely underutilized, and interesting, a sizable proportion of patients receiving digitalis. And I always remind, when I give this talk, the audience that in the 70s, when those trials were performed, the standard of care for gastritis and gastric ulcer was partial gastrectomy with vagotomy. Now, I have gastritis, and probably after the publication of the guideline, I may have an ulcer, and I hope that my treatment decisions are not based on what was the standard of care in the 70s. If we go back to the Lancet IPDMA, individually, only the European study showed a statistically significant reduction of mortality with surgery. For the other, there was a reduction of mortality around 5 years with surgery, but at the end of the follow-up, the curve started converging, and there was no statistically significant difference. In the pooled IPDMA, the difference between medical therapy and surgery did reach statistical significance, but you can see how the treatment effect was large at 5 years follow-up and then was smaller towards the end of the follow-up. And another important thing to notice is that the absolute difference was really small. Surgery was associated with a 4 months survival advantage over a course of 10 years. So even though statistical significance was reached, the absolute difference was was really small. So I don't think the Yusuf meta-analysis should be used at all for this debate. Regarding modern trial, there are 4 modern trials comparing CABG with medical therapy, and my personal definition of modern trial would be a trial where at least aspirin, beta blocker, and statin are used in the medical therapy arm, and the ITA is used in the majority of a patient in the surgical group. One of the problems with those trials that they were all including a specific subset of patients with low ejection fraction diabetics or isolated LAD disease. Only MAS2, that was a small trial, was enrolling in general patients with multivessel disease. So if we look at those trials relatively quickly, in the STITCH trial, we know at 5 years, surgery was associated with a reduction in mortality that did not reach statistical significance. Statistical significance was reached for cardiovascular mortality, and when readmission were included in the composite outcome. However, at 10-year follow-up, there was a statistically significant reduction of all-cause mortality in the surgical arm, keeping in mind that those were patients with low ejection fraction. In Bari 2D, in the surgical strata, there was no difference in survival, again, between the 2 treatment groups. There was a statistically significant reduction of cardiac events with surgery. And into 2 smaller trials, MAS1 and MAS2, where the results were consistent, no difference in survival, a statistically significant reduction in cardiac events with surgery. There have been a number of meta-analyses comparing in general revascularization versus medical therapy. The problem with those meta-analyses, those aggregate data meta-analyses, has generally been that the surgical and the PCI arm have been analyzed together. In this one, for example, data are extracted separately for the PCI and CABG arm, as you can see, but then there is a single pooled estimate. Same author gives separate estimate for MI, for myocardial infarction, and they found a statistically significant reduction of MI with surgery, not with PCI, compared to medical therapy. So overall, I do not think we got it wrong. The current guideline provide strong support to CABG versus medical therapy for reduction of cardiovascular events with a 2A indication, and a less strong support to CABG for a difference in survival, because in recent trials there is actually no difference in survival. There is new data, however, that have been published in online last week, and that they may potentially add something to the debate. We have performed, we have repeated basically the Lancet IPD AMA, only looking at those 4 modern trials that I have described at the beginning. It is still problematic because, again, the individual trial were focused on specific patient population, so there is a lot of clustering by trial. But we use individual patient data, and we try to adjust as much as we could. What we found is that over the course of a 10 years follow-up, there was in fact a statistically significant reduction in mortality with surgery compared to medical therapy. However, the curves were crossing clearly, and at around 2.5 to 3 years, there was a switch in the treatment effect. In fact, when you look at the time-segmented analysis, surgery was associated with a significant excess in risk in the first 6 months. There was no statistical difference in mortality between year 1 and 3, and then starting at postoperative year 4, the difference, the survival benefit for surgery becomes statistically significant. At subgroup analysis, younger patients and patients of non-white race benefited the most from surgery, and the treatment effect was, for the rest, consistent across key subgroups. So I think that the existing evidence seems to suggest that there may be a survival advantage, but there is for sure a reduction in cardiovascular events over the long-term follow-up with surgery compared to medical therapy. And I would respectfully note that this is exactly what the guidelines say. The evidence, however, is weak, especially for survival, does not reflect contemporary practice. I believe that the contemporary randomized trial is needed However, I anticipate that equipoise will be an issue. And with this one, I thank you for your attention.